Please take your seats. We're going to begin in a moment. All right, thank you very much. I'm Jan Park. I'm the governmental chair for the HIV Planning Council, and today is June 24th. In a moment, we'll go around the room and introduce ourselves. We're waiting on the Commissioner, Dr. Bassett, to join us. But before then, I would like to open our meeting as we traditionally do with a moment of silence, and I think I will ask Graham to lead us in that moment of silence.
So let's spend a moment and remember all of those people who have passed away from HIV, as well as those who have contributed to help people live with HIV, those who have the disease, as well as those as part of our community. That this has been a disease that affects all of us, and that all of us help to help people to live with it as well.
Thank you, Graham. Okay, just a couple housekeeping rules. There are some refreshments or food in the back. Restrooms are outside the doors. Please don't tweet, text, or email in the course of the meeting. If you feel so compelled to do that, you can step outside and show some respect for the colleagues who are here and present and in the moment. Robert?
Okay, great. Welcome, everybody. We're going to go ahead and start with public comment. I'm not sure if Daryl or David, if we have any. We'll go ahead and get started. No? Okay, great. So we will skip introduction of Dr. Bassett till she arrives. And you okay with moving right in? Or? All right. Let's go ahead and go through the packets, or through the packet, and Daryl will lead us through the packet, and we'll go through the minutes as well.
Good afternoon. After our minutes, we've got some biographies on our guests today. The first one is for Dr. Bassett, and then the next piece is our biographies for our speakers today, Mark Harrington, Jim Igo, and Jason Walker. Following that, we've got two pieces related to housing, which will be presented by Jason Walker. Next, a commentary prepared by Mr. Igo. Following that is the CDC PrEP Fast Fact Sheet, after which appears the ACT UP Atlanta Principles. There is then the Treatment Action Group newsletter from April 2014, and a piece regarding HIV prevention. Finally, summary comments revitalizing the HIV response to end the AIDS epidemic in New York City. I think those might be comments culled from the town hall meetings in December or after the elections. It seems to be reminiscent of that. After that is the grantee report, our planning council updates, and then two pieces of business for the Rules and Membership Committee, the bylaws amendments, which need a vote, and the nomination form for the community co-chair position, and then our July calendar, which will be the final meeting month of the year. Planning.
David, do you want to review the minutes?
Sure. Everybody got these in advance? Are there any changes, alterations, corrections, amendments? If not, they'll stand as presented. Thanks.
Okay, while we're waiting for Dr. Bassett, let's move to the
David, correction, my name is not on as present on the...
Oops. David, can you make that correction, please? Thank you, Randall. Graham, do you want to move into the grantee report, and Graham and Tom will present?
So direct you to the grantee report in your packets, and I'll just briefly go over the highlights. We received our 2014 grant score. We received a score of 95 out of 100 possible points. Strength identified by reviewers, worth noting, was the applicant organization concisely documents the needs of emerging populations, their unique challenges, service gaps, and estimated cost associated with delivering services to each population. On recommendation of the Needs Assessment Committee and the formal needs assessment submitted by the grantee and the Planning Council to HRSA, the New York EMA for the first time described emerging and target populations using the HIV care continuum to frame the discussion instead of traditional demographics. While demographics such as race, ethnicity, gender, sexual orientation, residence, and age were still discussed as part of the section on disparities in disproportionately affected populations, the section on service gaps discussed how Ryan White Services addresses the needs of people along the HIV care continuum. We'll be working quite a bit on the conditions of awards for the for our Ryan White Part A grant over the next few months, including a program terms report, progress report on last year's grant, as well as the MAI Minority AIDS Initiative Plan. These are all due over the next 2 months. So the Planning Council regularly submits information for conditions of award. For the progress reports, we review minutes and agendas and work products to write a summary of the activities undertaken by the Planning Council during the year. So it includes both achievements and challenges. Each year for the program terms, the Planning Council chairs submit a letter on behalf of the Planning Council certifying the spending plan and the 2014 prioritization. And then we also include a roster of Planning Council membership showing that we're in compliance with the legislative mandates. And we're in the midst or quite close to closeout, and I'm going to have Rachel Miller from PHS share a few preliminary numbers on the closeout. So it's very important that you know that these aren't preliminary, and part of the reason that these are preliminary is that the DOH-MH system may have additional unexpended funds that would go into a request and a final report that we'll bring to the council next month. But I want Rachel Miller to share the good news.
Pardon, Rachel, just if I may interrupt. Congratulations, Graham, and your team, and everybody else who worked on the application. They got 95 out of 100 points. Congratulations. we don't do that enough. You know, I mean, that's for anybody who has ever worked on these over the years at any point, it's very difficult, very complex, and you know, we need to stop for a minute sometimes and recognize that a lot of other EMAs got cut, and we did relatively well during a very challenging time, so thank you.
Thank you. I mean, it takes an enormous team to put that together, and everyone works very hard to get all the latest information and show New York at its best and brightest, and so we're very proud of that application. Thanks. Rachel?
Hey, everyone. So as Graham said, these are preliminary numbers. Well, actually, these are not preliminary numbers that I'm going to share with you for the subset of the EMA that I'll explain. It's not the underspending or spending results for the entire EMA because, as Graham mentioned, the health department is still finalizing its numbers between DOH-MH and OMB. But for the contracts that Public Health Solutions manages directly, and that's the lion's share, I'm pleased to report closeout figures for the year that ended February 28th. In the base award, where we had committed about $84 million, we had record underspending of $773, which is great. It was quite extraordinary. And the MAI award, where we had about $8 million of contract dollars, we spent all but, as someone said, a cappuccino, $3.78 left on the table. And so that really is a record, and we're delighted that money was spent by contractors doing the work that they set out to do. We wound up, as you know, we're pretty aggressive in managing the spending, so contractors that are not on track to spend their full amount have their grant awards reduced and redirected to programs that look like they're going to exceed, that are exceeding their targets. This year, more than 90% of contracts were touched in some way by either those reductions or enhancements. And of the contractors that were that overperformed in the base award, we were able to provide more than 3/4 of the amount that they overperformed by, by making money available through the reductions of the underspending contracts. We wound up reprogramming in that way over $6 million. So I think that's good news. And we'll give you the full EMA closeout report in July.
Yes, thanks.
Rachel, just really quick, that's remarkable. Can you put that in a context why that's important?
So HRSA, as many of you know, actually penalizes EMAs that underspend by more than 5% of their formula award, and formula is the lion's share of what we get. We would potentially lose the amount that we underspent by and become ineligible to apply for this competitive supplemental funding that we do so well on, 95 out of 100, if we had underspent by more than 5%. And as it is, the subcontractors underspent by 0%.
And historical context, is this new record for spending?
This is a record, although as I say, it's a record for subcontractors. We still don't have the EMA amount in total, but I think it will be a record.
And one last thing, complexity. How many contracts does that mean? What's the total amount?
We have about 200 contracts, and as I said, more than 90% were touched in some way, with more enhancements than takedowns this year.
I think we should say thank you. Thank you. It is amazing. For times when underspending was far, a much bigger gap, that trajectory of going almost basically to zero is critical in how we're viewed by HRSA, our funders, and I think it's important to note. Good luck topping that next year.
So an additional part of the grantee report, I wanted to share a couple intensive evaluations that we've done of different programs. The first one is a preliminary analysis of costs, HIV outcomes, and real-world determinants of success, which is the CORDS grant that we got through the National Institute of Mental Health in conjunction with CUNY, with Dr. Irvine as the DOH-MH principal investigator. So early analyses, and so this is a very intensive evaluation of the care coordination program. It's something that we don't have the resources to do with the Ryan White Administrative Fund, so we've done it by applying for an NIMH grant. So early analyses in the grant focusing on care coordination client outcomes show improvement in the areas of engagement in care and viral load suppression. And these outcomes were measured using the definitions of engagement in care greater than 2 CD4 viral load tests greater than 90 days apart, with greater than 1 in each half of a 12-month period. And then viral load suppression less than 200 copies per milliliter on most recent test in second half of 12-month period. So the results of these analyses are here, which show that 91% of people newly diagnosed were engaged 12 months after enrollment. 83% were out of care at enrollment. 93 were current to care at enrollment after 12 months, and 91% of those previously diagnosed were found to be engaged at 12 months. And then in terms of viral load suppression, 66% of those newly diagnosed were found to be virally suppressed, 50% of those out of care at enrollment, 51% current to care at enrollment, and then of all previously diagnosed, we see 51% were suppressed at 12 months, an increase from 32%. So we're excited to see those outcomes for a program that really focuses on those who have a medical need to receive additional support to engage in care and help them achieve viral load suppression. And I'll briefly go over the food insecurity data, and then I'll Dr. Bassett, should I turn it over to you now? Would you want me to just, okay. So food insecurity was reviewed for the food nutrition services funded in the New York EMA as part of the Ryan White programs. Staff in the REU unit in the care and treatment program examined its impact on client outcomes. Specifically, REU staff are examining the factors related to food insecurity among clients enrolled in the 11 food nutrition programs. So the study aim was to examine the differences in sociodemographic and clinical characteristics of Ryan White Part A funded food nutrition services with and without food insecurity, and to examine the association between food insecurity and viral load suppression in the client population. So 77% of those enrolled in Ryan White Part A food nutrition services experienced food insecurity, and the majority of these people did receive food assistance. But it's important to note that clients in the study who report food insecurity are 1.5 times more likely to not be virally suppressed than clients who do not report food insecurity. So I specifically chose these two evaluations because I think we're beginning to really collect additional data to really make the case that support services are crucial for engaging people with HIV and helping them to stay in care, as well as helping them to maintain a daily antiretroviral regimen. So incredibly important. We're publishing these results and getting the word out, which I think is really important for our services. So thank you.
Thank you, Graham. Dr. Bassett has joined us, and I would like the council to introduce themselves to her. She's new to you, and we're new to her. But she's not new to the department. She's been with us before, and we welcome her back. Her biography is in your folder. It's my pleasure to sit by her side. I've had the pleasure of meeting with her, and as have some of you who are part of our panel today. One of her earliest meetings was with the HIV community. To sit and listen to what our issues are and what work we've been doing and what work is anticipated. So let's go around the room. Please introduce yourselves. Tell us a little bit about from where you are and your time on the council. And I'll begin with Robert Cadero, who is a brand new father. His wife just delivered 2 beautiful boys. And
I want that to be my intro for the rest of my career. Thank you. So, yeah, their names are Daniel and Lucas, and they're in the NICU at Beth Israel. They were born 31 weeks. They're super healthy and kicking and making noise, and they wanted to get out early, so they're just like Daddy. So, Robert Cordero, community co-chairman, my last year. This is my swan song, looking for new leaders around the table to step up and become community co-chair, and I'm the president chief program officer of Boom Health in the Bronx.
Joan Corbisiero, parliamentarian.
Dan Pitchinson, the finance officer, newly with Montefiore Medical Center, formerly with the Cassier Network, Pro Mesa United Bronx Parents.
Daryl Wong with the Planning Council, staff at the Department of Health. I've been with the department for over 20 years, and about half of that has been spent with Ryan White programs.
I'm Rachel Miller from Public Health Solutions.
Dilva Martyr, DHS. I've been at DHS for 14 and a half years and on the Planning Council for 14 and a half years.
Hi, I'm Matt Bainey. I'm the director of the newly formed Institute for Advanced Medicine at Mount Sinai.
We encompass St. Luke's, Roosevelt, Beth Israel, and Mount Sinai, and I'm in charge of all their HIV services. I've been on the Planning Council second year.
I'm Alan Vergara. I work for the Physicians Affiliate Group of New York. I've been on the Planning Council for about 5 years. I'm the Chief Affiliation Officer for PAGNY's affiliate at Lincoln Hospital. And I've been involved with AIDS services for, wow, I don't even know how many years, but 5 years with this group.
My name is Adrian Guzman. I'm a staff attorney at the Center for HIV Law and Policy. This is my second year on the council, and I'm chair of the policy committee.
Good afternoon. My name is Amanda Lugg, and I'm the Director of Advocacy with African Services Committee. I've been with African Services Committee for 14 years, and this is my final year on the Planning Council.
Hi, I'm Kimberly Smith. I'm Vice President for Policy and Advocacy at Harlem United. This is my second year on the Planning Council, and I'm also on the HPG, HIV Prevention Group.
I'm Deborah Marcano, consumer from Brooklyn, and one meeting to go.
Hi, Leonardo Vicente, Executive Director of Bronx Lebanon Highbridge Woody Crest Center. I've been on the council for 3 years.
Zach Hennessy, Institute for Advanced Medicine. This is my first year on the Planning Council, and I'm also on the Integration of Care Committee.
Hi, I'm Freddy Molano. I'm the Vice President for Infectious Diseases Community Healthcare Network. Been there for 25 years. And this is my second term in the Planning Council.
My name is Mark Harrington. I'm from Treatment Action Group, where I've worked for the last 22 years, and I'm not a member of the Planning Council. I'm here as a guest. Thank you all very much.
Jason Walker, HIV/AIDS Community Organizer for Vocal New York, and I also coordinate their AIDS Housing Advocacy Network. I'm just a guest speaker for this afternoon. Thank you.
Hi, I'm Jim Igo. I'm also a guest. I'm from ACT UP New York. From 1987 to 1992, I worked intensively on HIV treatment issues, mostly on AIDS regulatory issues. And after a hiatus from HIV issues, I returned about 1.5 years ago to work on HIV prevention issues.
Good afternoon. Congratulations on your appointment as commissioner. I'm David Martin. I am a survivor of AIDS for 27 years. I work as the co-chair of the Consumers Committee. I've been with the Planning Council for 2 years. 1 year before that, I was a community member. I work also as a volunteer with the department, the Health Department, New York State, and some programs around the city that deal with HIV and AIDS. I use my life experience as a person with AIDS to better inform those bodies that I sit on, and I'm also a member of the MSM community.
Hi, good afternoon. My name is Randall Bruce. I'm a member of the Consumer, the PSRA, and the Needs Assessment Committee. This is my final year in my first term. I've reapplied for a second one. Hopefully I'll get it. And I use, like David, I use my experience as a PLWHA to help those who need the help.
Good afternoon. My name is Billy Fields. I'm first year on the Planning Council. I'm also co-chair of the Consumer Committee.
Good afternoon. My name is Felicia Carroll. So I've been on the Planning Council for the past for the past 8 years off and on, so different capacities, as co-chair to the advisory group that used to be in existence. Now I'm currently chair to the Rules of Membership, and I'm a member of the Consumers Committee and the PSRA. Welcome.
Good afternoon to all that's present. Thank you, Commissioner, for taking the time to come out here. And my name is Corinne Clemens, and I am a peer educator at AIDS Service Center of New York City. And I've been a council member for 5 years. This is my last term.
Hi, good afternoon. My name is Lisa Zulig. I'm the Director of Nutrition at God's Love We Deliver. I'm a registered dietitian, and this is my 3rd year on the council, and I've reapplied for a 2nd term as well. Thank you.
Hi, I'm Eunice Casey. I'm the HHC representative sitting in for Terry Hamilton. I'm the Assistant Director of HIV Services at HHC. I've had that post for about 5 years, and I've been the meeting appointee for that time.
Hello, my name is Kim Hernandez. I'm the Assistant Commissioner at the New York City Department for the Aging, and I'm representing New York City Department for the Aging at this meeting this is my beginning of my 2nd year. Thank you.
And I'm Tom Petro. I administer the Ryan White program at the Westchester County Department of Health for the Tri-County region. I've been there for 16 years. And I've been on the council for that long, but I was involved in the Ryan White program in New York since its inception. I came in 4 years with the Dinkins administration, and I worked 2 years under Mayor Giuliani as well.
Hello, I'm Lindell Urbano with Gay Men's Health Crisis. I have been involved with the Planning Council for several years as a policy committee member, but I've officially been on the council member for the last year. And prior to that, I served on the HIV prevention planning group for 2 terms, I believe it was. And yeah, it was. I look at Kimberly because she was there too. So, and yeah, that's what I want to share.
Good afternoon. God bless you. Welcome. My name is Pastor Jerome Payne. I've been on the council now, as I found out, for 5 years. I didn't know the time went by that fast. I'm on the Consumers Committee, council member. I'm with Brown Memorial Baptist Church in Brooklyn, New York, and we have the HIV/AIDS Voices from the Field committee. And I'm also with my own ministry. It's called Sanctuary of God's Holiness Traveling Christians Ministries, and we do a house-to-house ministry where we go out to people and to encourage them. But welcome.
Good afternoon. My name is Lee Hildebrand, and I am co-chair of the Needs Assessment Committee at the council here. And this is I think it's my 5th year on the council, my last year, end of my term. I am now adjunct assistant professor of human services in the City University at New York City College of Technology. And formerly, I'm now retired from a position as deputy executive director of clinical services at Turning Point in Brooklyn.
Graham Harriman, Care and Treatment in the Bureau of HIV. I'm also a person living with HIV for the last 24 years.
Hi, Sharon Duke. I'm the Executive Director of AIDS Service Center, NYC, DBA Allied Service Center. With all of the healthcare delivery changes, we've been expanding to treat other chronic conditions as well, using our HIV model of care and care management. And I also am the co-chair of PSRA, and proud implementer of a very robust peer education and training program.
Hello, I'm John Rojas. I'm the Interim Assistant Commissioner at the Bureau of HIV and AIDS, and I've been fortunate to work with my colleagues in the field of HIV/AIDS for it's been over 20 years now, so.
We're all going great together.
Hi,
I'm David Klotz, the Planning Council staff. I've been on the staff here at the Planning Council for 17 years. Started when the staff was at the mayor's office, and before that I worked at Gay Men's Health Crisis for 7 years. So add that up, that's how long I've been in the field.
And I'm Mary Bassett. I've been the health commissioner for about 4 months. So not, but all of us have lived with this epidemic for, gosh, it's now decades. And so I'm pleased to join you. I don't really have any particular agenda. I think I'm here to listen and to answer questions. And if I can't answer them, John can. So I met early in my tenure as commissioner, as you know. Maybe not as early as some people might have liked, but it took a while to get together so many busy people from the advocacy community. Some of you, I believe, were at that meeting. I think some people at that meeting have now joined government in high positions under the de Blasio administration. And so I had the opportunity to meet with members of the advocacy and community and people involved in community-based work and hear some of the concerns. I think largely the concern that emerged from that meeting is a concern that somehow HIV has become old news, and that it's not, that there's concern that it be addressed in a robust fashion in the new administration. Concerns that all of you actually confront concretely as in the Planning Council with the reduction in funds under Ryan White, which have been substantial and which are anticipated to continue. So a concern of reducing funds, less commitment at the same time as the community is aware of new scientific findings. And I wasn't trying to be rude. I was trying to find out whether Jay Varma was coming, because some of the work on genotyping or something, genetic analysis, he could speak to and I can't, and that came up in our meeting. But the whole area of the biomedical approaches to prevention has given a new window on HIV prevention. So a lot of our conversation focused on that. And so I don't know who's chairing. Am I chairing? No. You're chairing. Thank you. Sorry.
And Robert. Today's meeting is about the future of AIDS, and here's part of the future, and there's part of the future, and you're all part of the future. Many of us have been in this work for a very long time, and I know that Mark and Jim and I initially joined ACT UP, not realizing that we'd be sitting at this table today talking about HIV and AIDS some 30 years later, but we are. And many miracles have happened. I'm sitting here today, I think that's a miracle. And I thank Jim, and I thank Mark, and I thank everyone else in this room for being a part of that. So what I'd like the council to do today is we'll open this up to questions. Let's keep the questions focused on our work and what our abilities are, given the parameters of why we're here, but also what your thoughts are in improving the conditions and the lives of people with HIV and keeping high-risk negatives safe from HIV.
Would it be helpful to the group to know a little bit about my own background in HIV? Because I don't remember which version of my biography that you received. There's the very short and the very, very short. I like those the best, and this one looks like a bit longer. But for still the bulk of my working life so far, I lived and worked in Southern Africa in a country called Zimbabwe, a small country which has and still has one of the worst AIDS epidemics in the world, a different epidemic in terms of the initially affected risk groups than in the United States, but an epidemic of catastrophic proportions in terms of its impact on populations. as we also experienced here in New York City. So my first encounter with HIV was as an intern, or rather a resident at Harlem Hospital, before the disease had been described. And I think every doctor knew that this was a new disease because every physician remembers their first case. And then I worked largely in prevention. So someone down at this gym was saying he moved from prevention and treatment to prevention. So I worked largely in prevention in Southern Africa, in Zimbabwe, in all sorts of settings, in schools, in factories, working with women who were commercial sex workers, all aimed at prevention, largely through peer education, condom promotion, promotion of HIV testing, and also participated in a lot of research on prevention strategies like microbicides. And then treatment came, and I must admit that as a public health worker, that we were really, we were saved by the advocates and the Indian generic producers from not advocating strongly enough for treatment. I think for many people like myself felt the treatment was too expensive, too complex, and couldn't be implemented in our setting. And it was the advocates and the plummeting cost of drugs that really changed that. So that was a real learning experience for me, the importance of not letting the experts only guide this ship. And I think we've seen that as we went around the room, how that's really been a way in which HIV has changed the nature of how we do, how we tackle a disease. You know, the affected community, the infected population, the presence of community groups, technical people, all part of the solution, and that we really learned from HIV. So I went into treatment and became, you know, with the kind of zealousness of a convert, and was involved in some of the earliest access to treatment in the public sector in Zimbabwe, largely through research studies, which of course is how treatment first entered, became accessible to many people here in the United States. So, so that's my experience, largely in a developing country, largely in the face of a predominantly heterosexual epidemic. But I think, you know, all the issues are very similar. The unfortunate and negative competition between prevention and treatment, and the need to acknowledge and adopt new strategies. So that's my background. I never worked in HIV in this country, except as a clinician before the disease had been described. So you gave a really lovely presentation, and I guess now it's over to you and to the people gathered here.
Eunice?
I was just wondering if you could speak a little bit to any plans that may be in the works related to the changes that occurred in April that will allow more communication between the City Department of Health and the State Department of Health with linkage to care. A lot of our programs have a strong linkage to care requirement. Retention is a major concern, and making sure that there's more communication so we have a stronger sense of who's actually in care and who's not in care. So I just wanted to know if you could speak to that a little.
So we passed something in the, so we're very much, in terms of ensuring the impact of treatment, the linkage to care and adherence to care and retention of people in care is absolutely critical. So that is something that we are continuing to work on, and something that I know that there have been privacy concerns raised, but ones that we feel that all of the mechanisms in place at the department really strongly protect privacy and offer an opportunity for us to use access to databases to ensure that people who've drifted away from treatment can be identified and encouraged to return to care. Now, on the communications with the state, I'm not sure that I can answer that. Maybe I should turn to John.
We're still working with the New York State Department of Health on trying to finalize the regulations with the law. Oh, I'm sorry. Even before that, we've been working with HIV providers in the medical field on providing information on their clients, more de-identified information on who's engaged in care and who's not engaged in care, to give them more of a profile of how their patients are doing in order to better assist them, help their clients. But we still are working with the State Department of Health to fine-tune the regulations to make sure we're adhering to all laws. So I think more is to come. I've invited the team here, Dr. Braunstein and so forth, who work in our surveillance and epi unit, who could speak more to that if you like after the meeting.
Did that answer your question? Okay.
Matt? Sure, I thought I'd give it a shot. I am Matt Bainey from Mount Sinai. We are one of your sites that are funded for the sexual and behavioral health grants that are put out through the Department of Health. It's a great grant. It's doing really well, and that model hopefully will be able to be expanded in other areas. It's really excellent. My question for you is, with the uninsured populations right now, we can provide NPEP for those groups. What about PrEP? Do you have any ideas about that? Where are you going to go with it? I had to throw it out there. So
Yeah, you do have to
I know, I
throw
had
it
to throw
out
it out
there.
there. Go ahead.
So, I mean, some of you may remember that I was asked about this at the press conference that I when the mayor announced my appointment, and we are working on making PrEP available. PEP we've made available in STD clinics, and we're not promoting it as a service at these clinics, but it's obviously the STD clinics represent an appropriate way to target populations that are appropriate for PEP. We are beginning a process of educating physicians about PrEP. One of the challenges with PrEP is that often the providers themselves are not sure what they should be doing and aren't promoting it. And we also have, at least, I'm not sure of the timing, but we've developed materials that are, I've seen them in mock-up, I've signed off on them. I'm not quite sure when those public education materials aimed at the community of people who would be eligible, appropriately eligible for PrEP. And I'm not sure what the timing, I'm looking at John again.
Our PrEP website, PEP and PrEP website, as well as pamphlets on PEP and PrEP will be distributed in time for our Pride Parade this Sunday. So we're very happy to report that. We will also be launching, as Dr. Bassett mentioned, a public health detailing campaign in the fall, aimed at our physicians, our providers, and not necessarily ID infectious disease providers, obviously, because they're more attuned to the community, but non-ID physicians. And we're in the process of conducting focus groups with medical providers to get more input and make sure our detailing campaign is robust and encompassing of all, all.
I think, was your question, is the department going to buy and distribute PrEP? Was that was your question? I just think that we don't have the funding to do that. We want to make sure, and people are supposed to be insured now. Increasingly, we are supposed to. The Affordable Care Act is here. As a department, we've made an effort with the first round that ended on March 31st to ensure that people were aware of the opportunity, and we have enrollers ourselves and work with other groups to ensure that people were linked using our public access telephone number 311. So if you have insurance, that's the best thing. You should be able to get PrEP as well as other services. Although I don't know what individual plans are doing with PrEP, and the devil's always in the details on these things.
A challenge for some.
You're right. Our healthcare system is flawed. I think everybody knows that here, and that many of the people who benefit from Ryan White don't have alternatives within the health insurance system and for the services that they have received. And we have an incredibly expensive healthcare delivery system, and the insurance is expensive too. It's not as expensive as paying for your health care personally. It's much better to have, but it's still expensive and the deductibles are high.
Hi.
Zachary?
Hi, just to piggyback a little bit on this issue, we operate both HIV screening and access to PEP programs within the Mount Sinai system. And what we see is the patients who are being diagnosed newly positive, HIV positive, their demographics are very different from those who are presenting for post-exposure prophylaxis. So those who are presenting for post-exposure prophylaxis are more likely to be privately insured, white, younger, than those who are being newly diagnosed. So it appears that there's a barrier or a disparity in access and awareness. So are there any plans on the table for specific social networking or social marketing campaigns to address these issues?
I mean, this has been the main thing that I've been doing, looking at the data, concerned about the disparate burden of new infections and infections in general in communities of color, particularly among young men who have sex with men. So we're, this is something that we're aware of. It's part of the equity lens that I've been bringing to this work. But we don't have a specific program unless John is going to tell me about it. And I haven't heard about it. But we've been gathering up the data. We're worried about this. And it would be helpful to hear from all of you what the solution is for. I don't think it's a simple one for ensuring that we have people who we aren't reaching, who are getting infected, who we haven't been able to reach.
Freddie and then Jim. I'm not sure what your time limitations are here.
About 5 minutes, I think.
All right. Dr. Milano?
Thank you. Michael, it's more of a comment that every time that we have a successful intervention, somehow we do it so good that then we take the funding away and forget about the population. I think that the sexual behavioral health presents us with an excellent model to do the MPEP, and I think that, but it's important to also remember the women and the transgender population. We're including the transgender in the sexual behavioral health, but I was awakened by a woman last week who mentioned that she was in her 50s. She just found out that her partner was HIV positive, and no one is talking to them because we are forgetting people over 50. I'm 59 myself, and I still have sex. So I think it's important that we continue to remember these populations that we are aging, but we also living. And now that the life expectancy is getting longer, we need to make sure that when we plan about HIV, we include everyone, and including women and transgender and other persons. Thank you.
All right, we have time for one more question. Jim?
Yeah, just this is too follows up on what we were saying with respect to PrEP. Several people in this room were at a TAG event last Tuesday, and at that event, Sarit Golub and William Nazareth of the Hunter and Callan Lord PrEP demo project presented some preliminary information. And one of the things that struck me was, even though the demo project began about 5 months late, they have enrolled people in the demo project at about twice as fast as they had expected. And I talked to Sarit outside of the event during the break, and she was saying to me, so much so that the overflow is now going to Callan Lord outside the demo project, and they have people piled up to September. The project was originally designed so that people could either choose to go on PrEP or choose to remain in the study but not go on PrEP and have all the benefits of the added care. But virtually no one is choosing the not go on PrEP. They have been astounded at the interest in the community, and the CDC guidelines coming out have only compounded that. So I just wanted to prepare people. We have spent 2 years bemoaning the fact that nobody wants PrEP. We may now be at a moment where a lot of people will, and the question of how you pay for it. So Sarit said to me, I think there's a lot of pent-up demand, and the two things we're dealing with now is, one, we still have a lot of physician resistance, and of course, two, what you faced in Africa, price. There's just the price. It's hard to see getting the numbers on PrEP as long as the price of Truvada is where it is.
It's about, it's about 20,000 a year? That's what someone told me.
I guess about 14 and a half, I think, is more like it.
Okay. Right. You know, I mean, I think that we had activists lowered the price of drugs, and some, you know, I mean, I guess the one that's truly unconscionable is for Hep C, for goodness sakes. But, you know, these prices are too high, and you're right.
Dr. Bassett, thank you for coming today, and I hope this is not your first visit. We have a lot of work to do ahead.
I agree. Thank you.
Thank you.
It's really a pleasure.
On that note, I want to introduce our three guest speakers, Jason Walker, Jim Igoe, and Mark Harrington. As I mentioned before, our paths have crossed many times, and Jason is relatively new to this work, but he brings with him a lot of experience in other areas. What I put before our speakers today is a question about the future of AIDS, whether it's in research and evaluation, or it's prevention or treatment and care, specifically HIV housing in New York City, and how we intersect with all of that. Our speakers are aware that this is a planning council, that our turf, our domain, our funding is restricted to treatment and care, and it's restricted to very specific populations of people that don't have access to treatment and care through Medicaid or Medicare or the Veterans Administration, or if they're fortunate enough to be able to purchase private health insurance. So we estimate that number of people to be about 17,000 individuals that we serve each year. And the people that are sitting at this table, they're the ones that sign that check that pay for those services. And this is very unique to a federal piece of legislation that gives the authority to do that, to make those funding decisions, and puts that in the hands of the community. And this came about through AIDS activists who in the late 80s went to the federal government, walked the halls of Capitol Hill, drafted pieces of legislation that actually created the Ryan White CARE Act. And that's the legacy that has brought us to this table today. So we have experienced people in this panel who have seen all of this and who were there at the very beginning. And we have new people at the table who are now picking up the mantle and moving forward with the work. I came into this work in 1987, came into government service at the same time that I went to my first ACT UP meeting. And it was sort of coincidental that happened that way. I began doing HIV and AIDS work with Ed Koch in 1989. Much to the chagrin of people at City Hall, I continued to demonstrate and be arrested in civil disobedience acts until the early 90s. I never thought I would be doing this work that I'm doing today, but I did tell myself I would be in it until a cure was found. We don't use that word very often anymore, but I think that we should. I think we should re-own that word. We're getting much closer, certainly much closer than we were 5 years ago, 10, 15, 20 years ago. So I want that to be expressed here today. And I want giving each speaker 10 minutes, and I want you to be able to engage with them and bring your questions to them and have them bring their questions to us. So we'll begin today with Jason. Jason's been here before. He works with Vocal to New York. His beat is HIV and AIDS housing issues, as well as other areas of disparities for minority and low-income populations. He came to the council eager to present to us his vision and his organization's vision for that work, and we ran out of time. So I'm giving him time now as the first speaker on the panel. Jason.
Hello? Okay. First, good afternoon. I think it's still afternoon. For everyone for inviting me here. Really honored to be a part of this council today, and definitely sitting in between these two amazing gentlemen who the work I stand on their shoulders of, and the work that you all do collectively as a planning council and individually through your respective organizations. I've been diagnosed since I was 21. Well, actually, it was my 21st year. It was before my 20th birthday. And, you know, in getting involved in this work right now, I definitely appreciate all the support that you all have provided me as I enter this field as a newcomer. I really appreciate some of the support, of the encouragement, and of the assistance as I embark on carrying this legacy forward and doing all I can to help push my generation to be the next force to help really put an end to the AIDS epidemic. So I want to humbly demonstrate my gratitude to you all today. So now talking about the important stuff, the importance of AIDS housing in the future of ending the AIDS epidemic, right? We all know that housing is a critical component to ending the AIDS epidemic. We know that when people are stably housed, health outcomes improve, community viral load can go down, also help reduce the risk of transmission for both people who are HIV positive and people who are negative. Housing is also an intervention and a prevention. We know all these things. These are mantras in which we talk about in our HIV housing community. We know that the devastating impact that housing, the lack of housing or the loss of housing can have, especially on someone who has been stably housed, been linked into care, been adherent, been virally suppressed. When they lose their housing, their world is shattered and shaken. You know, they can have poor health outcomes. This was the case in the experience of those who had to pay more than 30% of their income towards their rent because of the lack of affordable housing protection found now through the 30% rent cap. HASA clients who were living in the independent housing program had to pay upwards to 70% of their income, the disability checks, towards their rent. So essentially a housing program that was supposed to provide subsidies for low-income people living with HIV/AIDS. It was actually HASA who was actually receiving the subsidy on the back of low-income people who are dealing with a chronic illness. So luckily, with the leadership of Bill de Blasio, with partnership with Cuomo, April 1st, they enacted through their state budgets, through their respective budgets, the 30% rent cap. So this is great news. It's been a #1 HIV/AIDS priority. Many of you all in the room in your respective agency has been a part of this and have definitely helped push this forward. This effort was definitely an effort that was succeeded and made successful because of the HIV/AIDS community. That was it by the end of the day. It was the community, people living with HIV/AIDS, service providers, and our allies in government who really put pressure on our political officials to make this happen. So it demonstrates that the fight and the strength of the AIDS community is still real, and it can definitely direct real change when it comes to public policy. That being said, April 1st, the 30% rent cap was passed. We now know that implementation of the 30% rent cap will happen on Monday, July the 1st, if my dates are correct. Is that right? Tuesday. On Tuesday, July the 1st. So the way the implementation process is going to work, HASA and HRA has decided through approval with the mayor that they were going to enact an emergency CAPA process, the City Administrative Procedure Act, where they're going to go through an emergency process because housing and the loss of housing is a real threat to people living with HIV/AIDS. So this week, HASA clients should receive a letter in the mail. HASA clients, caseworkers, and landlords should receive a letter from HRA and HASA this week informing them of their new budget, right? We'll let them know that this is a new policy, this is new law, and how it directly impacts them. So they should all receive that by Friday. My goal, I've been actually doing outreach in SROs and transitionals all morning because I wanted to make sure that the community knows this. Because if people do not get their letters by Friday, I would love to know that. Just so we can help keep accountability flowing between community and government. Also, we also want to be on alert to know if any people were any persons were denied when they received their letters. There's some people who may be denied. We hope that's not the case. But if that is the case, we're asking people to contact me so that we can figure out who's being denied, where on the income bracket they are being denied, and figure out whether ways we can help push to get them included into this affordable housing protection. Right, so if you all know of any clients who didn't receive a letter or did receive a letter and were denied the 30% rent cap, please inform Vocal, and we will do what we can to figure out how we can help remedy that issue. Cheat sheets. What else? So any questions on 30% rent cap? I mean, in the nutshell, implementation will happen on July 1st. Clients will get paid retroactively from April the 1st. They will be reimbursed for the money that they've been paying for April, May, and July because they have been protected under the law since April 1st. They will get their money back sometime, what we heard was sometime in late July, which is amazing. So we really are appreciative to the de Blasio administration, Steve Banks, definitely Dan Teese, who definitely came aboard. Many of you in the community know him, who's definitely really helping us out and making sure that our community pays their fair share when it comes to their rent. And also moving forward a lot of the other items that we're going to discuss relatively quickly that we feel are appropriate steps to help increase housing and the benefits of housing for people living with HIV and AIDS. So another issue that is very important is that Vocal New York, and I believe some of the agencies involved in this room today are part of this growing coalition calling for more New York housing, right? It's the Campaign for New York, spearheaded mostly by Shinny and the Coalition for the Homeless. Vocal New York is definitely wanting to pick up our efforts in helping making this a reality. And the campaign calls for 30,000 new development. We would like the new development of approximately 30,000 new units of supportive housing over the next 10 years, half of which would be contracting or constructing new housing, and the other 15,000 would be in scatter site. I believe 2/3 would be for individuals, and the remaining would be for families and who's the other? Youth and young adults. So Vocal New York is definitely devoting a considerable amount of time in making sure that we can help push for this campaign for New York for housing. I encourage you all, if you're not, if individually as your individual respective agencies and organizations, to sign on to be a part of this coalition. And as a planning council, use any type of influence you can use in order to help push this agenda forward, because the supportive housing units would definitely can help with some of the populations that you all cannot reach, that you all are not contracted to fund and support. So it's definitely great. Another thing that one of our main priorities is our HASA for All. HASA for All, as you all know, HASA only approves people who are only eligible for HASA are people who either have had an AIDS diagnosis or who are either symptomatic, right? And symptomatic is determined by the New York State, which means that you have to have either 2 opportunistic infections. There's a segment of the population who cannot access HASA for housing services, and mostly those are young people who are being recently diagnosed because they have not progressed to AIDS or have become sick enough in order to get housing. And this is, I think, the role of DOHMH and the Ryan White Planning Council and HOPWA funding programs, is to really assist us in making sure that some of our most vulnerable populations get access to these these life-saving housing opportunities, right? Especially because the reality of homophobia in the communities is displacement among youth, and usually when youth become displaced, this is usually the point where they contract HIV, and it's also help increase their risk behavior. So housing is not only a prevention, but it's also intervention, because many of the youth, once displaced, either because of their status or because of their homophobia within their family, opt out of care because of the stigmatization of being linked into care. So having safe housing is critical to our young population, because they need to achieve viral suppression. So I think one of the things in which the Planning Council can help, as we on the ground continue to fight to make HASA more open for that population, is really to devote some time in reaching youth who cannot access HASA until we build the campaign up again to really work with the government to open those doors for that community and population. I think those are the three primary things that we're working on. The 30% rent cap, New York housing, and also expanding HASA for all. And in the interim, really looking for the Planning Council, DOHMH, to really help us supply housing for people who cannot access HASA yet. I know that in the future there are some cuts coming down from HUD, especially for HOPWA, because of modernization. So we're anticipating and we're hoping that those cuts do not impact HASA. We're hoping that those cuts, do not impact DOHMH, because if those cuts impact DOHMH, people who cannot access HASA, immigrants population, people who are asymptomatic, cannot access those. So we want to make sure we protect DOHMH from cuts coming from the feds, because this DOHMH is the only place people can go for housing because they cannot access HASA housing, right? Because of either immigration status or because of their medical status as well. Open for questions, or we could do questions at the end. I don't know how it's going to go. But thank you all again.
If you don't mind, we'll wait till the end, because I think collectively what each of the speakers have to say, some of them will be answering some of the questions that are raised, but it will also facilitate the presentations better.
Hi, I wrote down what I want to say because that's the way I can say the most in the least amount of time, and I don't want to waste yours or mine. You've all seen today's agenda by now. You know that I'm supposed to be telling you in 10 or so minutes how we go about achieving the end of AIDS. 34 years into the stubbornly resistant HIV epidemic, that's kind of a heavy lift. I'm old enough to inform the younger among us that the end of AIDS has a history, even longer than the history of the organization I work with, ACT UP New York, even longer than the list of our joint accomplishments in fighting HIV. And when I say our, I mean the communities scarred most by this enduring epidemic, working in creative tension with the government agencies charged with helping us, the people, maintain individual and communal health. I remember sitting in an audience at a GMHC variety show fundraiser, 1985, where a group of chorus boys were singing, "We've found a cure for AIDS." The boys were all so excited by the prospect that they collectively dropped their pants and presented their asses to a drag nurse Ratchet's provocatively oversized hypodermic needle. The routine was more than an excuse for the chorus to show a little beefcake butt, well, a lot of beefcake butt, to a mostly gay male audience. It was also the celebration of the body at a time when many in my community of urban gay men of all races and ages had put their personal pleasure in the deep freeze, if just for the time being. Inoffensive on the face of it, this little skit set off a debate out of all proportion to its flimsiness. In the next issue of a community publication with a name I've forgotten, a prominent AIDS doctor argued that even after we have a cure for AIDS, gay guys would never be able to return to our pre-epidemic sex practices, read indiscriminate butt fucking. The rectum, the doctor warned us, is just too risky an environment. This column and the response it generated, much of it defending the ass as a worthy site of sexual desire and activity, forecast the debate that's been rippling across my community now that we have pharmaceutical prevention, PrEP, within our grasp. I'll return to sex before I close, but I think I was invited here today to say something about the community-generated initiative to make New York State the first government entity to set a due date, 2020, for the end of the AIDS epidemic as we know it, when, in a given year, there are fewer new HIV infections than there are the death of people living with HIV. I'm told that this initiative began over martinis shared by two old friends and ACT UP alumni, Charles King of Housing Works and Mark Harrington of Treatment Action Group. Their idea found favor with some in the AIDS Institute, including Dan O'Connell. Dan Tietz of ACREA was brought aboard, and these forces together, after having thought about it a lot, went semi-public last year in a series of meetings around the state and 3 here in the city that invited health department officials, HIV workers, and members from the affected communities to come together and talk openly about what it might take to end AIDS. Several ACT UP members attended those New York City meetings, including me. I'm proud of our contributions to those proceedings. We insisted that before we can declare an end to an epidemic, we have to have the best, most finely grained epidemiology science can obtain. The epidemic, we said time and again, will only be over when it is over for all subpopulations at traditional risk. The epidemic will not be over, even if general incidence is going down, if at the same time new infections are spiking anywhere, as they are right now among young gay guys, particularly guys of color and transgender women. We insisted that the epidemic will not end anytime soon if we rely only on treatment as prevention, or TASP, yes, the continued care and treatment that benefits individuals living with HIV also has a prevention benefit when a community's viral load drops enough that new infections become less and less likely. We welcome that. But even after significant gains, and a record that embarrasses most of the rest of the nation, it's estimated that about 44% of New Yorkers living with HIV have suppressed virus. ACT UP members argued that for us to end the epidemic, all available modes of prevention have to be running on all cylinders. In addition to TASP, this includes the pharmaceutical prevention of PrEP, and the behavioral prevention of using some combination of low-risk sex, using condoms for riskier sex acts, and other means of sexual risk reduction. Mathematical models of how we might achieve significant reductions in the current numbers of new yearly HIV infections support this triple prevention approach. And perhaps most importantly, ACT UP insisted that we will only end the epidemic when we start treating both people living with HIV and people at risk for HIV as full individuals with various needs. Here in New York State, with the advent of the Affordable Care Act and expanded Medicaid, we have the unique opportunity to enroll nearly all New Yorkers into sustained care. Might we not turbocharged the three major means of HIV prevention to an extent only dreamed of until now? We dare not miss this unique potential of this moment now that we might actually turn the epidemic around. And if a community-led initiative to end the epidemic by 2020 was a vehicle to achieve that, ACT UP was aboard. So were numerous community organizations and key personnel at the AIDS Institute. We began the year believing that we know what the next two steps were in this process. First, there were ongoing negotiations among state officials, community members, and representatives from the drug industry about reducing the prices of HIV drugs, both for treatment and prevention. It was estimated that in order to see a significant reduction in new HIV infections as a result of suppressed virus, about double the number of New Yorkers who now are on antiretroviral therapy would have to be taking antiretroviral therapy. Early on, one major drug company agreed in principle to price reductions of greater than 50%. Negotiations with other major drug companies continue, but have yet to produce an agreement that anyone is comfortable with announcing. The second step that we began the year anticipating was the imminent announcement of Governor Cuomo's appointments to a committee that would articulate particular measures the state would need to take in order to end the epidemic, and an earmarking of funds to support that committee's work. Not only has this announcement not occurred, there is fear among those who understand state politics more than I do that state enthusiasm for such a committee has cooled. Stay tuned. The coming week might see media events designed to gain some visibility for the end of the AIDS epidemic movement, both among the affected communities and general New Yorkers. After a 15-year vacation from HIV work, I returned to ACT UP a year and a half ago after the latest estimates on new HIV infections from the Centers for Disease Control and Prevention told me that among queer communities at least, a second HIV prevention emergency had begun. Within ACT UP, I work with the Prevention of HIV Action Group. FAG has not been content to let the end of AIDS lie with New York State, not when so much funding and regulation comes from the federal government. You might have heard that a couple of weeks ago, a bunch of us, ACT UP members, our friends from TAG, and new allies from several Atlanta-based HIV groups, met with CDC HIV prevention personnel to discuss our concerns with 10 areas of how the agency handles HIV prevention or doesn't. You have copies of a document we left with CDC, so I won't rehearse those areas of concern here, but I will articulate a few big principles that I think engage those of us in the affected communities who are working in prevention today. We told CDC, and by extension the world, that a fundamental principle of human subject research is that communities have the right to benefit from the knowledge obtained through research on them. After 30 years and a huge amount of research, we know how crucial TASP and PrEP could be for lowering the number of new infections. This knowledge must be translated quickly into policies and programs that could help relieve our communities of the massive burden of infection into the foreseeable future. We said that whether we are living with HIV or we're HIV negative, We have a right to basic health care and access to the information, drugs, and services that will help us maintain our health and the health of our partners. We returned a principle that AIDS activists have articulated since the beginning of the epidemic. People from the communities most affected by HIV are the everyday experts on the epidemic. We need to be full partners in designing and implementing all federal, local HIV prevention efforts. And finally, and this is the return to sex that I promised, we said that access to the full, that across the full spectrum of gender and irrespective of serostatus, individuals have the right to pursue sexual expression and maintain our health at the same time. It's tempting to end my remarks with a ringing endorsement of sex. Instead, I'll end like I began, with a personal story. Last Thursday, I was invited to attend a screening of the documentary How to Survive a Plague for a group of HIV-positive youth, working in a program in which they pick up cameras so they can document and express what living with HIV is like for the young and urban in 2014. I spent 4 hours with this group. I'll be returning next week when they present their final projects. For those 4 hours, this group of about 20 young people, among them graduates of this program who had returned to see the film and help their juniors, opened up to me, a stranger, which I think is probably the greatest gift one person can give another. No young person, no human being should have to go through the amount of pain and confusion and guilt and insult and fear and self-recrimination that these smart, beautiful, talented, loving, one-of-a-kind kids, and I'm old enough to call them that, have had to endure. At least 5 of them, my new friends, seroconverted within the past year. I work to prevent any further dimming of promise like the promise I saw in the room last Thursday. And I thank all of you in the community who are working for an end to the AIDS epidemic as well. Thank you.
Mark?
I want to thank you again for inviting us to all present. It's really an honor to be presenting after Jason and Jim. And one thought that came to me in the course of both of their remarks is that really we're at a period where the structures that we built over the last 30 years need to change because the science and the policy have changed. And one thing we need to put on the table is the CDC has asked for jurisdictions to consider how the prevention planning groups and the Ryan White planning groups can work together. And change is hard. But Jim just told you about some of the new discoveries in chemoprophylaxis and HIV prevention and how they rely on treatment. And now we have ACA, which is a platform for everyone who at least is eligible for ACA to get into care, which is a platform for both prevention and treatment. I would urge you, the DOH and this planning group, which is stronger and more empowered legally than the prevention planning group is, to reach out to that group and consider about ways how you could coordinate and collaborate your efforts, because in this era we don't have any resources to waste. And just like you heard from Jim, a whole new generation is in danger of being lost. I've been very proud to work with ACT UP and its Prevention of HIV Action Group and with Vocal on the social justice issues and the AIDS epidemic issues. You asked me to talk about biomedical research, and I'm really only going to talk about it very briefly and then talk much more about the implementation of that research in New York City. So, in the last 30 years, we've gone from having one drug to treat HIV to having over 36 drugs and combinations approved by the U.S. Food and Drug Administration to treat and now also to prevent HIV. We knew that one drug could prevent transmission of HIV from mother to child in 1994. And then for the last 3 years, we've known that one or two drugs can prevent sexual transmission, and they can prevent transmission among injecting drug users. We also know that triple therapy can reduce viral load to an undetectable level, prevent onward transmission, prevent transmission as much as 96% among serodiscordant couples, and can reduce viral load, can allow immune reconstitution. And in places that have universal health care like Britain, the life expectancy of a newly diagnosed person with HIV is equivalent to the normal life expectancy of an inhabitant of the United Kingdom. That's not the case here in the United States because of the flaws in our health system that many have noted before today. But it is within our grasp with ACA, with Medicaid expansion, and with some of the new HIV prevention and treatment tools that we have. Now, what are we not going to have in the next 6 years? We will not have a cure that can be scaled out to hundreds of thousands of people around the world or even around the state. We may have a few people that are cured, like the one baby in Mississippi that was treated extremely early. The NIH is doing a trial to see if they can replicate that in other babies who are infected in utero or intrapartum. But most babies globally are not detected with HIV until much too late, and even nationally, we have brought down new pediatric infections, so cases like the Mississippi baby are unusual, but they show us that that mother was out of care for over a year. They show us that a lot of people are still experiencing gross health injustice in our own country. And the adult who was cured, he had cancer twice, failed one transplant, and had a second transplant that was partially immune to HIV, and he's now living HIV-free. But the chance of dying on a stem cell transplant is about 30%. So again, this is not a scalable cure. Scientists are trying to replicate it, but we're not gonna have something that you can go to the pharmacy and get as a cure for several more years at the very least. With an HIV preventive vaccine, there are some new exciting discoveries with respect to neutralizing antibodies. They don't yet know how to create them with a vaccine product. And maybe one of the most exciting developments in preventive technology is going to be these long-acting injectable antiretrovirals that are now being studied by several companies. And they're going to be both studied for PrEP and also for treatment. So there's a couple of different products. They look like they're pretty safe. They look like they can prevent HIV infection in some animal models. They're going into studies for treatment, first for people that are already on treatment stably to see if they can switch from daily pills to like once monthly or once every 3 monthly injections. These are still quite far out from approval, and so we cannot expect them to be approved before, say, 2017 at the earliest. So I want to talk about interventions that we have that we can use to end the epidemic with what we already have. And I think Jim and Jason really set the stage, because really what we have around the room is the elements needed to end AIDS. We have the community, we have city government, we have activists, and those are those three elements have brought us to an amazing point where the death rate from AIDS has dropped by over 2/3 in this country, and where increasing proportions of people are getting on treatment. I would point out that the data that you showed from today about the percent that are virally suppressed, it's impressive that after 1 year, newly diagnosed, up to 66% are virally suppressed. But for those who've been out of care, who are current to care at enrollment, or were previously diagnosed, only about 50% of them are virally suppressed. And that shows you how much room there is to go just with treatment and retention and treatment success. And it's important to emphasize that because that's part of the remit of this committee and of the Ryan White program and the Continuum of Care initiative put out by the president. So when activists talk about the importance of other modes of prevention like housing or PrEP, it's not because we don't believe in the importance of treatment as prevention or universal treatment. We really have a very far way to go to get everyone who needs treatment now to be on it and to be successfully treated for the rest of their lifetime. But while we do that, using ACA, Ryan White, and Medicaid expansion and other modalities, we can also make a quantum leap forward in prevention. It's another reason why I'm asking you to start working with the Prevention Planning Group, because we're not going to end AIDS if we have a siloed approach to the pandemic. I'm going to talk about a couple new prevention tools that we have that are generated by science, or that should be generated by science. And Jim mentioned the importance of knowing your epidemic and disaggregating populations that are at especially high risk, like transgender women. And we do not have good surveillance in this country or in this city about transgender women. We need to put them very high on our agenda. They have the highest disproportionate rate of new HIV acquisition of any group in the country, including young MSM of color, which also we need to be able to disaggregate the epi data for those individuals, not only by race, ethnicity, but also by age, because there's such disproportionate HIV infections happening in young MSM. And then we do not do surveillance for sex workers in this country. It's on the UNAIDS list, it's not on the CDC list. We don't have any commercial sex workers in this country, or we're not measuring them. New York, you know, come on, it's 2015, it's 2014, let's get real and start measuring all the risk groups. There's a very exciting new testing algorithm that helps us to close the window between acute infection and diagnosis, and it's called fourth generation HIV testing. The CDC recommended it last year. It's going to put out new testing algorithm on Friday of this week. It's very important for New York to be out up front in using this new algorithm, because it's going to help us to identify those clusters of new ongoing transmission where so many new infections are coming from. In two really scary papers from last year, one of them was from Arizona. They used 2 emergency rooms in Arizona. They used the fourth generation test on everybody who came through the doors. And in both emergency rooms, over 44% of the HIV positive individuals who were found just through random screening in the ER were an acute primary HIV infection, just in Arizona, not even in, you know, New York City. And then in a study from Detroit that used the phylogenetic data, where they take part of your viral sequence when you get infected, and when you get diagnosed, and they report what mutations you have to find out if you're resistant to any of the drugs. They found out that 40% of the MSM in Detroit who got infected between 2004 and 2012, those infections happened with after they passed on infection within 40% of them passed on their infection within the first year of infection. So that 40% of all new infections come from people that are basically acute or just got infected in the last year. Those people are not being found through routine testing programs that are reaching the chronically infected. And so it's really, really important that and again, we're talking about young, mostly men of color, MSM. And they didn't address transgender people, but obviously they should have. Now, we talked about PrEP earlier. The city said they can't fund PrEP. Well, I mean, okay, first of all, the city should be helping everyone to get onto primary care. If you're not eligible for ACA or Medicaid expansion, the city should be working with the state to figure out a way for everyone who needs PEP or PrEP to be able to get it, whether it's through the patient assistance programs by the company or by another mechanism. And otherwise, we're going to have a huge amount of disproportionate new infections in people who aren't eligible for ACA because of their immigration status or because they're undocumented or ineligible for insurance, and that's unacceptable. If Mary, and I wish she had stayed for this part of the discussion, you know, if equity is the new mantra of the new administration in the city, and eliminating inequities and health disparities as part of their agenda, then they have to focus on these undocumented and in insurance ineligibles as a key population that is at really, really disproportionate risk for HIV, and to make sure that they know about and can access PEP within 24 hours and PrEP when they need it. Just another point about PrEP that came out of a study that was a 9-country study that was done in gay men and transgender women. There was a secondary analysis that was published earlier this month in the Lancet Infectious Disease by Susan Buchbinder. They're trying to identify which individuals benefited the most from PrEP. And it's extremely important for people to know this information, because we have to know how to target our interventions to who needs it most. 64% of the people who got infected in that group were individuals who, at baseline, reported unprotected, condom-free anal penetrative sex without receptive anal sex without a condom in the 3 months before entering the trial. So as Susan Buchbinder said at a meeting earlier this month, it's bottoms. That made up 64% of the people that got infected in the trial. The other group among who there was disproportionate infections was people with a recent history, self-reported, of a sexually transmitted infection. of syphilis and or of cocaine use. There was not enough crystal meth use reported in the study to talk about it. I think the reason for the high amount of cocaine use was because about half the patients in the study were from Peru and Ecuador. But it lets you know that certain kinds of drug-using behaviors are associated with an elevated risk of HIV, which we already knew, but we know it again. And so it shows us that there are individuals who are using substances that may have a disproportionate risk and may disproportionately benefit from PrEP. I wanted to mention that New York State has reported a very substantial increase in the number of proportion of HIV-infected New Yorkers that are having a treatment success and undetectable viral load. Between 2010, they reported only 37% of New Yorkers with HIV have an undetectable viral load, and that went up by a whopping 7% to 44% in 2012, which, like I said before, there's still a long way to go, but it shows that you could make a really big jump pretty quickly with concerted efforts. And that was done before the DHHS guidelines recommended everyone go on to treatment. The whole framework for the plan to end AIDS is in this Revitalizing the HIV Response. It didn't actually begin over a martini, though. It began at the White House on July 24th, 2 years ago at the International AIDS Conference, when the White House had announced a plan for a global AIDS-free generation. And yet domestically, we were facing this national AIDS strategy where we're calling for a 25% reduction in new infections, 25% greater increase in people who are undetectable with their viral load. And we know now that we need to get to 90% undetectable, and we need to bring down new infections by 80% or more to end the epidemic as an epidemic. And so there was a global march on the White House. 13 people got arrested, including Charles King and I. And the plan was hatched in the van after the arrest, where we were sitting with our plastic handcuffs tightly bound in 106-degree heat in a very hot van of the National Park Service on the way to jail, where we began discussing what eventually became the community-generated New York plan to end AIDS. Now, again, PrEP is expensive, but we don't need to pay the sticker price. If we can pressure the governor to announce and launch the AIDS plan and to announce and launch the task force to design and implement the plan, Gilead has already agreed to provide a rebate of around 68%. The exact number is not something that I know, but it's very substantial. So that price goes from $12,000 to $4,000 a year. It's still not low enough, and in other countries you can get the combination generically for less than $200 a year, but it's very substantially lower than the sticker price that's reported in the press. If we don't have a plan, Gilead's not going to give us that rebate. Gilead's responsible for over half of the market. We have companies that are responsible for over 70% of the market have already agreed with state Medicaid to sign on to the plan. We need to rattle the governor's cage so that he steps out and signs up for this plan. Otherwise, we will still have to pay sticker price for these drugs. We won't have 70% rebates for ARVs. We won't be able to make it possible to treat and prevent our way out of the epidemic with the tools that we have now. So that's something that all of you can help us with, is pressure the governor's office to sign on to the plan, and then together we can work to pressure the remaining companies to come on board with the substantial rebates to state Medicaid that can make it possible to implement this plan. One other important idea that we've been talking about with the CDC, with the AIDS Institute, and with the DOHMH that I want everyone here from the community to know about is, because we now can identify those who are at greatest risk of new HIV infections, as Susan Buckbinder did from the IPREC study, we can enroll people, we could consider enrolling people who sign up for PEP or PrEP into a statewide chemoprophylaxis registry that would follow them prospectively to see how they did, what their side effects were, how their treatment completion was in the case of PEP, whether or not they decided to stay on PrEP or used it as a gateway to other effective prevention tools. And then when these new long-acting injectables come along, we would have a platform to introduce them on. But we can also, this is a group that is at disproportionate risk of getting HIV infection. And there's now phylogenetic data where we can use to intervene on acutely infected networks. the issue that Zach brought up about difference between the group accessing PEP and the group that is getting infected is something that's really important, that we need to close that gap, because it's unacceptable that some people are getting infected while other people are accessing a proven evidence-based prevention tool that replicates the same kind of inequities that have driven this epidemic for the last 30 plus years. And we need to make sure that the people who need the services know about the services and get the services. And we could use a chemoprophylaxis registry to help level the playing field so that those who need high quality prevention services are able to enroll in it. And again, all these initiatives would continue to put New York at the forefront of the nationwide and also the global struggle to not only to manage AIDS, but to end it. And I salute all of you in this room. We have literally centuries of experience fighting this disease, and it's only because we've been able to work together that we've been able to come so far. And let's go all the way, and let's end AIDS, at least in the lifetimes of some of us, so that other generations don't keep have to suffer getting infected and suffering the way that we have. Thank you so much.
Thank you to all of you. We have a little bit less than 15 minutes. There's some other items I think we're going to have to table for the meeting. But I wanted to open it up to see if there were any questions. I know folks were jotting down notes, so we'll open it up. Yes, David.
This question is for Jason, and it's pertaining to the application process for housing. It's been my experience, and also from others' feedback, that there is a question that is asked what kind of subsidies you're receiving on the application process, in the application when you're applying for an apartment. And I think that lends itself to be a tool for discrimination. Do you know of that, or have you investigated that?
Are you referring to specifically with HASA or with CBOs or with landlords?
No, this is not specifically with HASA, because I'm assuming if you're with HASA, then the landlord already knows, but this is outside of HASA.
Well, legally, no landlord is supposed to ask an individual where their source of income is coming from, right? Because that opened up the ground for discrimination. So there's a lot of work that we're also trying to brainstorm on ways on how we can help strengthen that law and make sure HASA clients are protected, because there should not be a question asking people where their source of income is, because that can lead to housing discrimination. So, yeah.
All right, but this is outside of HASA. So.
Yes, yes,
okay.
Yes.
All right, anybody else? Sure, Dan.
Mark, so you were encouraging us to contact the governor's office. So has the governor shown any inclination, or has there been talk that the office is in favor of the plan, or is it just, it seems like June lots of bones get thrown to us because it's, LGBTQ month, yay. So is there anything, is it something that's way off the radar, or is it something that seems that they've talked about and they're...
It's very much on their radar. In the fall, Governor Cuomo authorized Jason Helgerson from the Medicaid office in the state government to negotiate rebates with pharma around the HIV commodities, drugs and diagnostics. Jason immediately he went for where the market share was, which was Gilead, and then they went through all the other companies. They notified us, the community coalition that's been working on this, that not all the companies were on board. We started talking to all of them. 2 more companies came on board. Other companies, the negotiations are ongoing literally right now. I mean, they've been calling and writing to the state this week. We had originally asked the governor to name the task force when he presented his budget. He didn't do that, but a lot of other major things were achieved, like the rent cap. They're definitely aware of it. He's running for re-election. The thing that he's worried about is maybe a lobbyist is going to come to Albany and say, you're hurting my drug company's ability to innovate. Well, he's already got 70% of the market on board. So we as a community need to say, look, Governor, we need your leadership here. The community can't lead on this alone. We need all the companies aboard to be able to afford to treat and prevent everybody. They're very well aware of it, and they've gotten another letter from us. They're going to get a negative op-ed if we don't hear from them by Sunday. But we're still going to ask for it after Sunday if we haven't gotten it by Sunday. So yeah, they're aware of it.
Thank you.
It just seems to me that for all three of your comments, there seems to be a screaming need to have more collaboration between government agencies and also between these organizations. And I'm hopeful that the Medicaid, similar to the Medicare redesign team, there will be this team for the end of AIDS in New York. And I really hope there's a push towards that. I've noticed that there's, a lot of territory and territoriality that goes on in HIV in New York with the government agencies, with hospitals themselves, with different groups. And I think unless we have that leadership, we're really not going to get past it. And I just wanted to also voice my support for your idea of a registry for PrEP. Working directly with some doctors, I know every time you have a conversation about it, there's concerns about, well, what if this patient goes to my doctor, gets this drug, and then goes and sells it on the corner and goes to somebody else? And this hesitation that doctors have, I think a lot of it is ignorant based, but there's also some concern with the ones that do know what goes on in these communities, and that this can very much get blown out of hand. And something like a registry really could provide that overarching support to help people get more effectively into care, so you don't have 50 different sites sort of doing the same work, but you have one overarching agency that's working together with those 50 sites to make sure everything's getting done.
Thank you. We do have actually a couple of items that the council does need to vote on, so if there's a final question or comment. Adrian.
This is kind of a good wrap-up question for all three. I think that as a government entity, the Planning Council is oftentimes struggling with exactly what we can and cannot do when it comes to some of these issues. I know it's a discussion that we have at almost every policy committee meeting. There are some things, some restrictions that are very clear. We can't take a position on a specific piece of legislation, for example. But there's ways in which we can, aside from disseminating information and getting it out to different networks, I guess I'm asking if you have some ideas for how you think that we can participate and move forward some of this work as a planning council, short of, as I said, supporting specific legislation. If you have some ideas, I know that the planning council and specifically the policy committee would be interested in how we can move this work forward.
Well, I already mentioned the idea of trying to work with the HIV prevention planning group as a way forward that would really help to make sure that resources don't go to waste, and we have a coordinated strategy here in New York City.
And could I say this is more as community to those of you who come from the community rather than what you can do on this board. Mark and I met with the CDC 2 weeks ago and a day, I guess it was 2 weeks, Monday. And while they're all, I'm sure, committed workers and lovely individuals, there was no urgency from that side. Not the urgency that those of us in the community can see when we see the ongoing epidemic and that it is settling into pockets that are just harder and harder to reach. So my fear is unless we can get all the community to stand up and say, hey, among some of us, there really is an emergency, that we're not going to move these huge bureaucracies to do very much. So it's really more in your capacity outside this room than in this room that I really think you can do the most by just getting all the community members to understand and just to say, we do not want this epidemic forever. We have 50,000 new infections a year and have for 10 years, and we don't want a never-ending epidemic.
Also, I think supporting the development of 30,000 new supportive housing units through the New York can definitely help create the opportunity for you all to reach more people. So I think the development, the supporting of that would be critical. And also, I think for the most part, outside of this, Vocal does a lot of the policy stuff. So when it comes to HASA, but I think like the development and the creation of 30,000 new supportive housing units would definitely help a lot.
Thank you, Jim, Jason, and Mark. It sounds like it's just as a community co-chair, what I would ask Adrian is that you as the chair of the policy committee, just look at all of the recommendations, everything from the Atlanta principles, the 30% rent cap, 30,000 new supportive housing units, and see what falls within our purview or not. One option that we always do have is that I can sign letters on behalf of community to, oftentimes to the mayor or to the federal government. We send one on trying to lift again the federal ban on syringe exchange. So there's things that we can do that's not the official capacity of the council, but that also comes with the letterhead of the New York EMA Planning Council, and has enabled us sometimes to get meetings or to get things on the radar of elected officials that might not otherwise. So I'd like to ask that we filter it through the committee, and Adrian moves really quick, and that you have, I'm sure, Mark, Jim's, and Jason's cell phone numbers and ways to get in touch with them, and offer that this be a continuing conversation. I think the point that Jim made at the end was critical about just ensuring that there be a sense of urgency. So thank you so much for taking the time, all three of you, for coming today. We really appreciate it. We're going to turn it over to quick hit items that we need to address, and I'm going to pass it back to Jan and his team.
I'd just like to echo Robert's remarks. I'm really proud of you guys. I've seen you work over the years and watch you grow and prosper and in a good way help so many of us. And I really appreciate that. And personally, I just want to thank you for taking the time out of your schedules and to be here today. And I'm hoping that everyone at this table has learned something new that they didn't know when they walked in the door previously. All right, we have some business to take care of. David, it's about our bylaws. Would you like to move that?
Sure. Actually, this seems so insignificant after those presentations, but we do have some technical things we have to accomplish. There are two items near the back of your packet. One's a set of bylaws changes that was presented at the last meeting. Questions were raised about a couple of issues. We went back actually to our parliamentarian, made some revisions. One item actually allows us to hold meetings via conference call, which we've never been able to do before. We've kind of had unofficial conference calls, but this would mean that we could actually have a scheduled meeting by conference call if it's actually necessary. And we've done it for the executive committee. It's been successful. The questions that were raised last time were how would they abide by open meeting laws. We do post on the website that anybody that wants to call in from the public can get the number from us. And also, would people be able to vote on a conference call meeting? And the suggestion was that if it's a meeting, people should be able to vote. So the amendment just simply states that, upon the co-chair's consultation, that a committee or the council can conduct a meeting by conference call, and that they are subject to open meeting laws. The other item was about time-sensitive issues, so that the executive committee can vote on an urgent issue by email. And then finally, just some technical fixes, because there have been some changes in reporting lines and people's titles. So that's just changing things like assistant commissioner to deputy commissioner, and disease control from policy and external affairs. So if there are any questions, if not,
so let's move this quickly. Thank you, David. Let's get a motion on the floor, because planning council staff can't put the motion on the floor. David, you have a question?
Yeah, I did have a question. I posed a question last time about getting minutes approved in a conference call. Is that possible? And
yeah, currently not. These changes would allow that to happen. So.
Yes, Alan.
I'd like to make a motion to accept the amendments to the bylaws as proposed.
Is there a second? Matthew, thank you. Call
Any more
question,
discussion?
ready? Any further discussion? All in favor, raise your hands. Thank you. All opposed? Motion passes as presented by David Klatz. Thank you.
And
Both items, right, or is it just one?
Yeah, and then
Right.
one other item, Robert's retiring. He's got a lot on his hands, 2 kids, so we're going to have an election at the next Planning Council meeting for a new community co-chair. There's a form if you'd like to submit a nomination. The duties of the co-chair are laid out here, and encourage people to apply. Any non-governmental member can run for community co-chair.
All right, one last thing, Tom Petro. We need an update from our suburban brothers and sisters in Westchester, Rockland, and Putnam counties.
Thanks, Jan. So we closed out also, and we thought we had a record as well until we were shamed by Rachel and company for achieving less than $1,000 in underspending. But we had about $105,000 in underspending. We allocated $53,000 to Public Health Solutions, actually for the New York City reprogramming plan, and that left us with $51,880. We have developed a carryover plan, or a proposed carryover plan, which we'll bring to you at the next council meeting after it goes through the exec committee, hopefully. And also, I just wanted to mention that Victor Alvarez sends his regrets for not being here, but he had surgery this morning, and he's in recovery as we speak, and he's doing well.
Thank you, Tom. All right, our work is just about done. We have one more meeting, which is on July 1st. At that meeting, we will decide on how to spend money in 2015.
July 31st.
Sorry? July, what did I say? Oh, July 31st. Okay, so there's a lot of committee work that is wrapping up this month, and please participate so that we can end the session with a new mental health service directive, a home care directive, and a new budget that will accommodate the changes that we are seeing happening around us in our healthcare environment. Gentlemen, thank you again. Do I hear a motion to adjourn? So moved. All right.
Motion to adjourn.
Enjoy the summer, and we'll see you in a few weeks.